Good evening, everyone. It's a real pleasure and privilege for me to be able to talk with you this evening. I have many connections with India and many very good colleagues all over India, and I wish I was there in person, but this is the second best. So tonight I want to talk a little bit about the 2017 American College of Cardiology, American Heart Association Guideline for prevention, detection, evaluation, and management of high blood pressure in adults. And from here on, I'm going to call it ACC, AHA for ease. And there are three things I want to focus on. The first is process. I won't spend a lot of time, but it's important to have some understanding of process. And then I'll go over some of the principal recommendations, and then I'll focus a little bit on comparisons with some of the other major guidelines. I am at the Tulane University School of Public Health and Tropical Medicine and the Tulane University School of Medicine here in New Orleans in the southern part of the United States in the Gulf of Mexico. I have no conflicts of interest. Just as a disclosure, just so you should know, I chaired the writing committee for the 2017 guideline, and I've also chaired a number of the major trials that were influential on the guideline, including SPRINT, ALL-HAT, TOPE, and TONE. Now, one thing we should say about guidelines is they are very useful and they are at the core of clinical practice. They're especially helpful in an area like blood pressure, where the condition is common, where it is expensive, certainly to society and oftentimes to the individual, where practice patterns vary, and we know that control rates for blood pressure vary tremendously between countries and within countries, and where you have a sufficient body of evidence and it's of appropriate quality. And certainly that applies to blood pressure. So not terribly surprising that the first major cardiovascular prevention clinical practice guideline that was published was the Joint National Committee report. It was initially published in 1977. Over time, there were many other JNCs that were published. They were very, very helpful. They became progressively more structured, comprehensive, and sophisticated. And the final JNC was published in 2003, the JNC 7. In the US, between 2003 and 2013, we had several other guidelines. They were important, but they were of limited scope. They mostly focused on aspects of antihypertensive drug therapy. And then in 2013, the National Heart, Lung, and Blood Institute decided it was no longer going to develop guidelines, and it passed that responsibility over to the American College of Cardiology and the American Heart Association. That group identified blood pressure as the area that was in most need of updating with a new guideline. And they spent about a year doing outreach to other professional societies in the US to encourage them to partner in the development of a new guideline. And then about a year later, our writing group was formed. We worked for 3 years, developed the guidelines over about 2 years, and then spent about 1 year in a peer review of the guideline. Now, the guideline is written for the US specifically. There are aspects that are very transferable to other countries, but there are some aspects that are less transferable. So as I mentioned, it was driven by American College of Cardiology and American Heart, but many other professional organizations with an interest in blood pressure. The Academy of Physician Assistants, the American College of Preventive Medicine, Geriatric Society, the Pharmacists Association, the American Society of Hypertension, Society of Preventive Cardiology, Association of Black Cardiologists, the National Medical Association, and the Preventive Cardiovascular Nurses Association. So pretty good mix representing those who are involved in the care of patients with high blood pressure. There were 21 members on the writing committee. It was a multidisciplinary group. No one on the committee had a relationship with industry producing devices or medications for management of blood pressure. I won't go through the individuals on the committee. I will just say it was an outstanding group that covered many areas of interest. There were 2 lay patient members. I had a wonderful vice chair. We've known one another for many years and we complemented each other's strengths. So everyone was very engaged in the development of the guideline, including the 2 lay participants. We also had an independent external review committee. We gave them certain questions that we had developed by PICO methods and asked them to do systematic review and meta-analysis for us. We gave them 4 questions and they determined for 3 of those they could give us answers, and for 1, comparing monotherapy with combination therapy, they said there was an insufficient quantity and quality of data to give us an answer. The process was highly structured, very standardized. It follows the ACC/AHA Guideline Task Force process, which is largely modeled on the Institute of Medicine recommendations for how to develop a guideline. It is a long guideline because it's comprehensive, it has to be, but we set it up in a way that should be easy to navigate. So there are 15 sections and a lot of subsections, and they follow exactly the same process. They all start with a recommendation or a series of recommendations, and there were a total of 106 recommendations. Those recommendations are characterized by class of recommendation, or COR, the strength or the importance of the recommendation, and also a level of evidence, an LOE, saying the quality of the evidence that supports the recommendation. For each of the recommendations, we provide the key references, and then we provide a little text, a synopsis, and sometimes a little more detail underpinning the rationale for the decision or the recommendation. There's a huge body of additional data, including 448 evidence tables to support the recommendations. And in addition to writing the guideline, it underwent extensive peer review. That included internal review and sending it out around the world to about 50 experts in the area, including experts from India. We got about 1,000 comments. We had to respond to each of those comments, give a rationale for why we either accepted or did not accept the recommendation coming from the experts. And then after all of that was done, it went back to the 11 professional societies and went through extensive review there and was eventually approved by their governing bodies. So whether one likes the recommendations or not, I will say that they're based on a great deal of care and thought, and I'd like to think that they are good recommendations. Now, I'm only going to pick out a couple of highlights from many in the guideline. I want to talk tonight briefly, underscore the importance of accurate blood pressure measurement and the use of out-of-office measures. Talk about our new classification system, our new approach to treatment decisions, lower targets for blood pressure during treatment, and then talk a little bit about strategies to improve blood pressure control. So let's start with blood pressure measurement. And I will say that when I started many moons ago in the 1970s, we knew all of the factors that would lead to inaccurate estimates of blood pressure, both the predictable or systematic errors and the random or unpredictable ones, and how to manage them. And we've had that in guidelines over many years, and sadly, in practice, we do a really bad job of getting accurate blood pressure measurements. And what needs to be done, we go over in detail in the guideline, is fairly straightforward. You know it as well as I do, preparing the patient properly, using proper technique, getting proper measurements, documenting the readings, averaging the readings, at least 2 readings on at least 2 occasions, providing the readings to the patient. These are all fairly straightforward things, but not always followed in practice. Now, if a laboratory didn't meet quality control standards, we would shut it down immediately. If we got on an airplane and the pilot said to us, I've got a list that I'm supposed to follow, but I'm busy today and I know you want to get to your destination and we're not going to bother with it, we would be horrified. But sadly, patients come and they really get poor quality measures, and it leads to misdiagnosis and mismanagement. So that's something that we emphasized very strongly. Now, we also emphasized out-of-office blood pressure readings. We recognize increasingly that what we see in the office is valuable. It underpins most of our clinical trials, but it's limited. It gives us a small window on what the body is doing during the daytime. And we know that there is a great deal of discrepancy between what we find in the office and what we find outside the office. Now, if there is sustained hypertension, high in the office, high outside the office, then we know that person is at high risk and will benefit from treatment. On the other hand, the phenomenon of white coat hypertension and masked hypertension are both shockingly common. White coat hypertension, of course, being high in the office but normal out of the office, or at least not hypertensive out of the office. Those people in most studies have a risk profile that is much closer to normotensis than it is to sustained hypertension. With no clinical trials testing the value of treatment here, but our expert opinion was that they don't necessarily all need immediate drug treatment, and they can be followed with non-pharm. There is a pretty good percent that will graduate each year to sustained hypertension, so they need to be followed carefully, but they probably don't need to be treated so aggressively. On the other hand, more insidious is masked hypertension, where they have normal pressure in the office and then they go about their daily responsibilities and their pressure is high. And those individuals in almost every study have a risk profile that is very similar to sustained hypertension. Again, there are no clinical trials to really give us the best guidance for treatment, but common sense, expert opinion would suggest that treatment is probably sensible in masked hypertension. So that's new in providing that sort of advice, especially for masked hypertension, and both of these are quite common. We provide a lot of algorithms in the guideline. I won't go through them. It's just to say that what I've mentioned to you in form of text you can follow very easily by way of figures. We classified blood pressure, and I've shown here a panel with systolic and diastolic blood pressures here on the left-hand side of my panel. In the center part is the classification system recommended in JNC 7. It's the one that was introduced in JNC 5 in 1993, and most of us have followed this classification system for the last 20 or 30 years, and we modified that a bit. So we looked at what was previously normal blood pressure, less than 120, less than 80. We thought that was a very sensible designation. We left that just as it was. We looked at what was previously designated as hypertension, and we felt above 140 systolic, above 90 diastolic, that was also sensible, and we kept that as hypertension. There was this group in the middle, the so-called pre-hypertensives, or at an earlier time was called high normal blood pressure. We didn't like that terminology, especially for the upper part of that distribution. Systolics between 130, 139, diastolics between 80, 89. We felt that based on risk, on average, those individuals have about double the risk of a heart attack or a stroke, and there were lots of treatment trials that suggested getting to pressures below this level would be beneficial on average. Both non-drug trials like PREVAIR, which shows you can regress left ventricular hypertrophy, and many drug treatment trials. So we felt it was important for patients to know they were at risk and that there were treatments that were beneficial, and they should be labeled stage 1 hypertension. So we labeled on stage 1, everything else stage 2. For this group, we used the term elevated blood pressure. We didn't like the term pre-hypertension because it is likely to suggest to patients that they don't have hypertension. I'm pre that phase. It's an orange light, but I don't need to do anything. High normal, the same thing. It suggests that I've still got normal, maybe high, but it's normal. So we just felt you need to say what it is. We recognize that this would have a big implication for prevalence, less for treatment. And of course, this is all based on proper blood pressure measurements. Now, in the US, that distributes, using our classification system, it distributes as about 42% normal, about 12% elevated, and almost 50%, 45.6% with hypertension. About 14% stage 1 hypertension, about 8% with untreated hypertension, and then about 24% who are being treated, but they're still hypertensive. They're not being properly treated. So that's how it spelled out. Compared to JNC7, as I mentioned, about a 14% increase in the prevalence of hypertension. That's about 31 million additional adults in the US. Of course, it would be a much larger number in India. Now, what about the threshold for treatment? Well, we looked at the threshold for treatment, and traditionally what we've used is blood pressure to make decisions. And of course, blood pressure is a good indicator of risk, and we know that clinical trials reducing blood pressure are beneficial. This is one of the classic reports. There are a couple of them. This is the prospective studies collaboration, and it shows a striking relationship between increasing level of blood pressure and increasing risk, in this case for ischemic heart disease, but also for stroke and other outcomes. A little steeper at younger age, but still very impressive at older age. It's there for systolic and it's there for diastolic blood pressure. So blood pressure is in itself a useful indicator, but if we look at atherosclerotic risk, we know that atherosclerotic risk varies tremendously at the same level of blood pressure. So you can have somebody at the same level of blood pressure and huge differences in the likelihood of an atherosclerotic complication. You can see that here for an average systolic of 110, here for an average systolic of 130. For an increase in blood pressure, say going from 110 to 130, there's a very small change in the risk of atherosclerosis for those at low risk. For those at higher risk, there's a much bigger impact. And when we look at the blood pressure treatment trials, the relative reduction in risk with treatment, in other words, the percent improvement with treatment, is pretty constant across underlying cardiovascular risk. But the absolute benefit, which is what a patient is interested in, is hugely dependent on underlying cardiovascular risk. So with that in mind, we felt that it was time for blood pressure in the US to do what our colleagues dealing with lipids have done for some time. Take atherosclerotic risk into account. And when we look at the treatment trials, we've shown over many years now that benefit is a mix of how much you're able to lower blood pressure, but very importantly, in the short term especially, the number of events prevented is going to be heavily dependent on underlying cardiovascular risk. So those at higher risk will derive greater benefit from a reduction of any level of blood pressure. So that led us to say that it ought to be a mix of blood pressure and underlying cardiovascular risk, especially for that stage 1 hypertension group. So up here, for everyone, it's good to have a healthy lifestyle. From here, for the elevateds, we recommended non-foreign therapy, but of course, when you get down to this level of hypertension, it becomes much more, you have to be graduated up to be more on top of the situation. For those with stage 1 hypertension who are otherwise at low risk, we recommended non-pharm alone. And this is mostly going to be lifestyle improvement. And that's about 70% of individuals with stage 1 hypertension in the US. For those who had stage 1 hypertension with high underlying cardiovascular risk, and we determined risk using the AHA-ACC pooled cohort equation. It takes about 14 cohorts, including Framium, the granddaddy of all of these risk predictors, pools them. And coming from the trials, we used 10-year atherosclerotic risk of 10% or more, and that's the type of people who have been in our drug treatment trials. So for this group, we recommended not only non-pharm, but antihypertensive drug therapy from the outset. Now, we said for individuals who have diabetes, if you're an adult and you have diabetes and you have high blood pressure, you're very likely at high risk. About 90% of those individuals would meet this criterion for high risk, and likewise for chronic kidney disease. So we said, it's good in everyone to do formal estimation of risk, but as a practical matter, you can assume high risk in this situation. And likewise for older adults, and we use the cut point of 65 years, if they have high blood pressure, they're almost certainly at high risk. And we didn't change anything with those who have always been designated as hypertension. So for all of these groups here, we recommended the combination of underpinning of non-pharm, lifestyle improvements, and drug therapy. And of course, the underpinning of blood pressure, about 10% have traditional secondary causes of high blood pressure, but most people have high blood pressure because of poor diet and lack of physical activity. And again, I'm just showing you here the type of algorithm or guideline recommending how you walk somebody through the treatment process. Now, because we are more careful about who should get a drug, even though the prevalence of hypertension goes up dramatically with our classification system, the percent of individuals who are recommended drug therapy only changes slightly because we're more selective about who should get drug therapy. And I want to talk now a little bit about targeting. And many people have said your guideline is heavily influenced by SPRINT, and that's true. SPRINT was important, and I'll come back to SPRINT in a moment. So even before SPRINT was published, there were 19 trials available. None of them had sufficient power to answer the question of the benefit of intensive blood pressure reduction on their own. But collectively, when you pool them, what you would find is an overall benefit. And I'm sorry, my little circles are supposed to circle the overall benefit, but I inadvertently moved them. But they demonstrated benefit for cardiovascular disease overall, for myocardial infarction, and for stroke. Not down to levels as low as SPRINT, but down to about 130 over 75. So we knew before SPRINT was published there was likely benefit from going to lower than traditional pressures. SPRINT, as you may know, was a large trial. It was a very powerful trial, and it was stopped early. It was stopped after a little over 3 years because the benefit of intensive blood pressure reduction was so dramatic. And the primary outcome was a composite of cardiovascular disease outcomes, the traditional ones, and it showed about a 25% reduction at the time the trial was stopped. Would have gotten bigger over time. And more importantly in many senses was the primary secondary outcome. Now, normally we don't power our trials to look at all-cause mortality, but when you see an all-cause mortality difference, it's very powerful because obviously death is a very powerful outcome. and it's almost impossible to get it wrong. You know whether somebody is alive or dead, and you don't make a mistake. It's not like, did they have a stroke, did they have a heart attack, we're a little unsure. This one, you're definite, and it's a very powerful outcome. So that combination of the primary and death from all cause was very powerful indication, and this trial was big enough that it could answer the question on its own. So it added. Now we felt sprint was important. I will tell you that when we discussed sprint, because I chaired it and there were two others on the committee who were very involved with sprint, we stepped aside and I asked my vice chair to handle all of those discussions. Now some people have said, well, okay, sprint shows benefit, but you measured your blood pressure more carefully than others have. And it is true that we followed guideline recommendations for measurement of blood pressure, but many other trials have done that, some even more rigorously. Some people have said, well, you used an arm-on device and all of your measurements were unattended. And that's not true. We never said that. We had a mix of attended and unattended for a variety of reasons. And there are now about 6 trials that have looked at this question, some with relatively small sample sizes. Ours had by far and away the largest sample size, but they all show there is some difference between attended and unattended visits when you're using an automated device, but it's modest. And there are factors that are much more important in influencing the level of blood pressure. So I don't think we can ignore sprint because of that, and we cannot do what many people have suggested, well, just bounce the pressures up 10 millimeters. That's not a good way to think about it. What we should be saying is we need to measure blood pressures properly. Here's the largest meta-analysis done by our group here in New Orleans, and it's looking at, it's a network meta-analysis. It's got tremendous statistical power, and it's looking at randomized comparisons between different levels of achieved blood pressure. And look at the 120, 124 versus, in this case, relatively high pressures, 160 or above, dramatic improvements. As you ratchet down the comparisons here, the improvements are still statistically significant. They are mitigated somewhat. But even down here at 120, 124 versus 125, 129, you still see additional benefits. So what this suggested, this meta-analysis suggested, that there was a graduated benefit from more modest reductions to more substantial differences in blood pressure. This was for major cardiovascular disease here, but you see the same pattern if you looked purely at stroke or coronary heart disease or all-cause mortality. Similar pattern whether you included the sprint results or not. This is a network meta-analysis, but if you did a traditional direct meta-analysis, you see exactly the same findings. It's just you have less power. Now, there are many others who've done meta-analysis that show the same sort of findings. So I think it's very convincing. Now, I'll just show another meta-analysis that I think is an interesting way. This is what we would call a sequential meta-analysis. It starts with the oldest trial comparison of different intensities of blood pressure reduction, the so-called HOT trial in 1998. And then it sequentially adds in trials as they become available. And you'll see there's a suggestion, here's a line of identity here, there's a suggestion of benefit from the outset, but it's got wide confidence intervals. And then as you progressively add in, things begin to stabilize, you're getting more power. And then you'll see from about the 4th and 5th trial on down, the best estimate doesn't really change very much. It's quite stable. The confidence intervals become tighter, so you have more confidence around the best estimate. So I think what this is saying is, yes, sprint was a great trial. It answered the question on its own, but it really is just we should have been suspecting from the trials that had gone before it. But to me, it's very convincing that the benefits are. We asked our evidence review committee to look at this question for us. We specifically asked them to look at 130 over 80 because we were thinking about that. And they did a meta-analysis, a direct meta-analysis in 19 trials. And again, they came back to us and said, yes, we see very definite benefit for major cardiovascular events, for MI, for stroke, for heart failure. So based on the totality of the findings, including our evidence review committee's meta-analysis, we felt very confident that at least we could recommend 130 for systolic. Now, diastolic, we don't have any recent trials that have used diastolic as an endpoint, but the feedback we got is clinicians would like to have guidance around diastolic, so we used 80 as an equivalent level of blood pressure, but our confidence and our COR is very high for systolic, and for diastolic it's based on expert. So this is what we ended up, 130 over 80 for most individuals with hypertension. For those who are older, and as I mentioned, we arbitrarily use 65 and above, there, typically what you see is, of course, a wide pulse pressure with relatively low diastolics. Most of the risk is predicated by systolic blood pressure. So we said here what you really need to be following is systolic, and you could just go for a systolic below 130 on its own. The recommendation, and this is just a summary slide, I'll pass on this. I'm going to come back to comparing with other guidelines, but let's just start by saying where are we in targets compared to what others are recommending. So the Canadians in 2016, they update annually. Their updated 2016 and including their 2017 has based on SPRINT intensive blood pressure treatment to targets of 120 or less in high-risk patients. So they're a little more, they recommend a slightly lower level of blood pressure than we did. And of course, they say shared decision-making, safe implementation of intensive blood pressure reduction. A little later in 2016, the Australians came out with their updated guidelines, and they liked, based on SPRINT, less than 120 can be helpful, and they graded that as strong. Grade B is the strongest for the Canadians for a single trial, and it would have been grade A with more trials. And the Australians, of course, recommended it appropriately. Close follow-up to identify treatment-related adverse effects. In the U.S., the American Diabetes Association has recommended a target of 140 over 90 for all diabetics with high blood pressure, 130 over 80 for those at high risk. Well, I can tell you that an adult with high blood pressure and diabetes has a very strong probability of being at high risk. Minimally 90% are at high risk. So we're pretty much identical with the recommendation. What about other groups? Well, one group that I think we all worry about is intensive blood pressure treatment in older adults. And let me talk about them. Now, one of the groups that we recruited in SPRINT was older adults. We selected a lot of people with underlying kidney disease and a lot of older adults. And so they're a pretty good sample size, about a little over 2,600 participants that were 75 years or older at baseline. And when we looked at their pattern, it was identical to the overall experience. Those who got intensive blood pressure treatment fared much better in terms of the primary outcome and all-cause mortality. And of course, because they were at much higher absolute risk, the number needed to treat to prevent an event was much smaller than the overall number needed to treat. We went one step further and said, well, let's look at the most frail older participants, because those are the ones we'll worry about the most. And we looked at that in two ways. We had an indicator, well-proven, validated indicator of frailty, and what that suggested to us was whether somebody was deemed to be fit, rested, or indeed frail, they had the same pattern. Even though when they were frail, they had a very high risk and lots of events, they, on average, seemed to do better from lower levels of blood pressure during treatment. We also looked at gait speed, which is something one can do in practice very easily. I mean, you do it and I do it. You observe patients coming in. And those who have a slow gait speed have a very low morbidity and mortality. But again, in that group, lowering their blood pressure seemed to, on average, provide good benefits. So that was quite reassuring. We took a look at diastolic blood pressure. A concern, of course, is when you're treating systolic, you will concurrently lower diastolic. And what about the individuals who start with a low diastolic? Maybe we would take their diastolic too low to perfuse the coronary arteries. And there have been a number of reports of J curves that I'm sure you are aware of. And the recommendation has been, okay, we see a J curve, so at low levels of diastolic, be very careful about lowering blood pressure. Well, they're all based on observational analysis, sometimes tricky because they use a clinical trial data set and you can be confused because you can see the trial name, but it's actually an observational analysis. I do a lot of observational epidemiology and we see J curves all the time. So you will see a J curve with not only blood pressure in many instances, particularly with sick groups, but you'll see it with alcohol, you see it with cholesterol, you see it with body weight. It's a very common phenomenon in observational epidemiology. Now we looked at SPRINT, and when we looked at baseline blood pressure, here are quintiles of baseline blood pressure. We saw for both the intensive group and the standard group in an observational analysis this sort of U-shaped or J-shaped curve. Those with the lowest diastolics at baseline had some of the highest risk. And on the other hand, the proper analysis to do is a randomized comparison. So this group here are at high risk. They got a lot of events. But when we compared randomly the effect of standard treatment or more intensive treatment, on average, they always did better with more intensive treatment. So I think what this is telling us is that when you have a low diastolic, you've got stiff arteries, you're probably sick and you are at risk for events, but you do benefit from treatment, whether it is looking at the primary outcome or all-cause mortality. These are some of the other subgroups in SPRINT. All of the subgroups, the experience we had was that whether you had or didn't have something, you seemed to do better. So for instance, with chronic kidney disease, whether you had chronic kidney disease or you didn't have it, on average, you seem to do better with more intensive reduction in blood pressure. We didn't have diabetics in SPRINT. That was an exclusion, but in the meta-analysis I showed you from our group earlier on, about 30% had diabetes, so there's a strong suggestion that a more intensive reduction is also beneficial in diabetics. We did have pre-diabetics, and when we looked in the pre-diabetics, the hazard ratio was very similar to the overall hazard ratio, suggesting strong benefit from more intensive reduction in blood pressure. Now, what about the other side of the coin? If you accept that there's a benefit from more intensive treatment, what about risk? Are there side effects? Well, of course there are going to be side effects. One of the side effects that we know to be demonstrated in many of these trials is electrolyte abnormalities, and that's not surprising. We're using more diuretic, we're using more ACE and ARB, so you will see statistically significant more hyponatremia, hypokalemia, and hyperkalemia. It's not common, but it is certainly more common in the more intensively treated group. The other thing that we see consistently in all of these intensive treatment trials is a reduction in estimated glomerular filtration rate. I'll show you here the experience for the participants in SPRINT who had CKD at baseline. So there is a change, and you see it very early on, and then it's pretty constant from there on out. It's significant, but it's not very big. It's about a 3 mils per minute per 1.73 meters squared estimate. And it doesn't lead, none of these trials, it doesn't lead to a significant change in estimated GFR or to end-stage renal disease. And in many of these trials, when you stop the treatment, the GFR goes back up. So it seems very likely that it's a hemodynamic effect of the drugs we're using to lower blood pressure, and probably not a very serious concern. What about serious adverse events? Well, our FDA designates a serious adverse event or an SAE, as I'm showing up here on the slide. Pointer. Most of the trials don't provide much information, if any, on serious adverse events. The two trials that provide more useful information are ACCORD in diabetics and SPRINT, which I've been talking about. And SPRINT provides the most comprehensive information. Now, in SPRINT, there was no overall difference between the two treatment groups, more intensive and standard care, for SAEs. There were some SAEs, more SAEs seen in some monitored participants in SPRINT, and it was almost entirely due to a hospitalization. So in some settings where a clinician, in this case it was a physician, saw hypertension, syncope, electrolyte abnormalities, was designated as acute kidney injury, acute renal injury, or acute renal failure, that led to hospitalization. Now, it's hard to interpret these complications. They need to be interpreted cautiously, because for beneficial outcomes, our ascertainment in the two arms was identical. You could only recognize the beneficial effects at specific study visits. For ethical reasons, we would accept an SAE by any means, a phone call, etc. So there's more opportunity for SAEs in the intensively treated more often. That's one problem. And the other problem is trying to understand the biological consequences of some of these findings. And it doesn't seem that they are biologically in any way beneficial outcomes. So overall, I would say electrolyte abnormalities, we should be on the watch for that. It is not common, but it's going to occur in some patients. Some risk of hospitalization. Clearly, the balance of benefits and adverse effects cannot be weighted equally. Preventing a major cardiovascular event and death is more important than some of the adverse events that seem to occur. But even if you weighted equally, you would come to the conclusion, this is a group independent of SPRINT, that there is benefit from treatment. And the last thing I will say is that a good clinician, of course, can recognize and manage or mitigate adverse effects when they occur. Now, we do have generalizability of event-based clinical trial findings. No question that all of the landmark trials, including SPRINT, enroll participants who are volunteers. They're predominantly coming from the US and Europe. So, when you're in India, you have to be asking the question, is what's being seen in the US and Europe generalizable to India? Probably is, but we can't be 100% sure about that. There are selected samples, however, many of the trials, including Sprint, went to great trouble to get a selection of participants that would mirror needs for clinical practice. And all of these trials are at high risk for CVD. For event-based trials, we recruit only people who are at high risk. So that is clearly a selection. But having said that, when you think about who do we treat in practice, they're high risk too. And this is a community practice. It's a good, nice, random sample of general practice patients in Adelaide in Australia. We used exactly the same indicator of risk that we used in Sprint, the Frailty score. And here is the overall risk experience in Sprint and the risk experience in the 75 plus, and you'll see it mirrors what we're seeing in clinical practice. So the reality is, when we're in clinical practice, we are typically seeing older patients, and they often have comorbidities. So that general issue is not such a big deal. Now, all of them have been so-called efficacy trials. That is, we test the intervention under more favorable conditions than is usual in clinical practice. So, for example, in Sprint, we provided the medications free. We recommended use of the drugs that have been best proven to be effective in clinical trials. So, for instance, for diuretics, we recommended chlorthalidone, which I know is not readily available in India, but you have indapamide. It is a long-acting agent. It's much more, seems to be more effective than hydrochloric equivalent. We monitor our participants carefully. We follow the recommendations for measurement of blood pressure. So yes, these are efficacy trials. By definition, most of us try to follow evidence-based medicine practice, and so that would be the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients or in public health about the care of populations. And I would say, despite the challenges in generalizability, which are real, randomized controlled trials provide the best underpinning for our decisions, our treatment decisions in clinical practice. Another thing I want to touch on when we get a comparison with other guidelines is strategies for improving control of hypertension. We know that control rates were abysmal. My colleague Catherine Mills, who's with me in our group, updated an estimate that we first developed in early 2000, and this is quite recent. And the best estimate now for the 140-90 is control rates that are worldwide only about 14%. If you get to, this is buoyed by individuals in high-income countries. If you get to countries that are low, middle-income countries, it's even more discouraging, about 8% overall. And it's particularly bad in those in low socioeconomic settings in those countries. Now in the US, we have about the best control rates that one would find in any other country except for Canada. And roughly for our general population, control rates to 140, this should be 140, excuse me, it says 149, it should be 140 over 90. About 53%. And that's good, and we've seen progressive improvements, but it's not as good as it can be. We know that in settings where there is a systematic approach to improving control rates, we can do much better. And in many systems of care, where we're dealing with insured patients and we have a systematic approach to improving control rates, we've pushed those control rates up from 40 to 80, and now most recently people are reporting 90% control rates. This is in one of the private insurance organizations, Kaiser Permanente in Northern California, but you see the same thing in the Veterans Administration reports, Here at Tulane, you see the same thing. So many systems of care are doing much, much better. And of course, there are groups who are doing worse. And in our country, it's young people, especially young men, and especially young black men. They don't get into the care system. Now, we looked at those systems of care. What are they doing right? And there's a very nice publication from my colleague Catherine Mills in Annals of Internal Medicine recently. She shows the evidence for some of what I'm showing here. We show evidence in our guideline as well. So some of the things are things that we all recognize to be important. Adherence strategies are job number one. There's no reason to use anything but once daily dosing. And if there is an appropriate combination pill, that makes far more sense than trying to use 2 or 3 drugs on their own. Certainly strategies to promote lifestyle modification help with control rates. Team-based care is very well proven and very powerful. And the team, of course, starts with the patient and clinician, whether it be a physician, a nurse, or a pharmacist. We know that pharmacists and nurses, oftentimes under the direction of physicians in the U.S., have been very, very powerful in improving control rates, shared decision-making. But in enlarging that team to include staff in the office or on the outside, community health workers, and others, spouses, relatives, friends, getting the team involved really has been very well proven to improve control rates. Active use of the electronic health record. Now, passive electronic health record does nothing to improve control rates, but active use, especially when it's used as a registry to see who among our patients are controlled, who are not, why are they not coming for visits, are they not? That helps us to zero in on the people who need more attention, and that's proven to be helpful. Telehealth strategies with feedback mechanisms, performance measures and quality improvement initiatives, and to a very limited effect, statistically significant, but not very powerful financial incentives. So those are the things that are best proven to improve, and they can be quite effective. And last, I just want to compare our guideline with some of the other guidelines relatively recent. So there are 5 common guidelines, JNC7, which I've talked about before, the European guidelines, the Australian guidelines, the Canadian guidelines, our guideline. There are many others, but these are all independent guidelines that generate independent data. So they're useful to compare. And then there are at least 4 focus guidelines in the US that we look at. So KDIGO looking directions for kidney patients, the JNC8 panel, which was looking at drug therapy only, the American College of Physicians, American Academy of Family Practice, which was looking at drug therapy only and restricting that to adults 60 years or above. And the ADA looking at care of hypertension and diabetes. So most of these recommend lifestyle for most adults. Drug therapy in the comprehensive guidelines, generally speaking, see if I can find my little pointer here. Here it is. Generally speaking, the threshold for treatment in most of these guidelines up until recently has been 140 over 90. We are, as I mentioned, recommend 130 over 80 for those at high risk, 140 over 90 for all others. KDIGO 140 over 90, JNC8 panel 140 over 90 for less than 60. Curiously, for above 60, they recommended 150 over 90. ACP, AFP, for those over 60, they recommend 150. For those at higher risk, they recommended 140. They didn't look at 130. The ADA recommended, as I mentioned, a threshold for recognition of hypertension is 140/90. And what about drug therapy? Well, drug therapy, for NC7 was 140/90. No explicit influence by underlying cardiovascular risk. Although the European guideline talks about underlying risk when it comes to the treatment recommendation, is purely based on blood pressure. The Australians recommend 140/90, but as I mentioned, for high-risk individuals, a systolic of 120 or less. Canadians, likewise, 120 or less in the high risk. 130/80 for us, but the strength of our recommendation gets stronger and stronger for higher underlying atherosclerotic risk. KDIGO 140/90, but consideration of lower pressures for those with albuminuria. JNC8 panel 150/90 for those 60 or above, but there was a lot of discord within this panel, and they didn't have access to many of the trials that we had access to, but even at that time, there was a minority report published in the annals, and they said 150 is ridiculous, we should stay with 140/90. ACP-AFP, as I mentioned, 150 for high-risk individuals, individuals stroke, TIA, they're also high-risk, less than 140, and for moderate evidence for 130/139. ADA 140/90 for high risk, 130/80, which is most diabetics. So there's increasingly, as we get to the newer guidelines, they're all tending to suggest lower targets than we've traditionally had in our guidelines. So with that, I'm going to stop. I'm going to thank you very much for your attention. Certainly a great pleasure to be with you this evening, and I look forward to exchanging ideas by way of questions and answers. Okay, so what is the drug of choice for isolated systolic hypertension in diabetic patients, as diuretic is known to have adverse effect on glycemic profile? Well, what we do know in diabetics, and we had quite a number of diabetics in ALLHAT, where we had the best shot at comparing first-step therapy with diuretics, ACE inhibitors, and CCBs, but that they all worked well. Lowering blood pressure is the key, and although there are some metabolic effects of both diuretics and of ACEs, they don't seem to be critically important. And the type of hyperglycemia that you get with diuretics, it's there, it's real, it's modest. When you compare it to a CCB, which would be metabolically neutral. But there have been a number of studies, including ALLHAT and SHEP, that have done long-term follow-up of those individuals, and that type of drug-induced hyperglycemia does not seem to carry the same risk as the hyperglycemia that we would see, the traditional hyperglycemia that was usually occurring because of diabetes, often driven by overweight or obesity. So I think the drug of choice is getting blood pressure down. The key, and almost all guidelines would say this, the key is getting blood pressure down. If somebody has diabetes and heavy proteinuria, there is strong evidence that ACEs are beneficial, and to a lesser extent, evidence that ARBs are beneficial. So we typically would say ACEs, if they're tolerated, and they are tolerated by most people, if not tolerated, ARBs. As you get to more modest proteinuria, the evidence for the benefit of any particular class is less dramatic. So most of these patients are going to require combination therapy, and I think a good combination would be a long-acting diuretic with an ACE, If you don't have access to labs, then CCB is a good substitute for a diuretic, a CCB with an ACE or an ARB. So that would be my thought on that question. Will not control blood pressure help in prevention and remodeling of heart failure? Yes, and we have. I'm not the expert in this area, but we had quite a number of cardiologists on our panel. And we have a good deal of information around our recommendations, not only for blood pressure reduction in HFrEF and HFpEF, but the particular drugs. Our general recommendations for targets would be 130/80 in most people with stable ischemic heart disease and most people with heart failure. The choice of drugs would be different. Because you've got a compelling indication. So the choice of drugs typically would start with an ACE. And there is a good deal of detail that you will find in our guideline dealing with this particular question. What should be the target for first-time diagnosed 40-year-old male smoker, central obesity, deranged liver function, desk job, positive family history, CVD? So clearly, when we get to this age range, typically when we're looking at event estimating atherosclerotic risk factor estimates, like the one we used, they are best used for 45 or above when you start to see events. So this person is just coming into the ballpark where event-based risk calculators are useful. When you get to a younger age, then you're looking at lifetime risk. The events don't occur typically if you're looking at somebody in 30, 35 or thereabouts. They're not likely to have an event in the next 5 or 10 years, but the concern is lifetime. So there we have to look at lifetime risk. In this individual, I would say a traditional risk calculator will be helpful. Sounds like somebody who is at quite high risk. They're 45, they're male, they're smoker, they've got central obesity, deranged liver function tests, positive family history. There are red flags going up all over the place, so you could be very confident that this person is going to be at high risk. Suppose his BP both on the opposite heart side were recorded at 130, 139, 82, 86. I would say that given the underlying risk for this individual, they are very likely to benefit from blood pressure lowering. And clearly, in this person, it would be really important to counsel them on changing their lifestyle. Stop smoking. That's an obvious one. And it's not easy to do. It's easy to say, but it's not easy to do. But it's going to be really important for this individual. Get physical activity. And we provide in our guideline a lot of tips on how to achieve some of these non-farm lifestyle improvements. But in addition to lifestyle, which will be very important in this particular patient, I think drug therapy is called for. In the US, what we would typically start with would be a long-acting diuretic. So indapamide would be a good choice in India. But you could start with a calcium channel blocker, especially if labs aren't easily available. Calcium channel blocker is nice because it's metabolically neutral. You could start with an ACE. We looked at the panoply of classes of agents, and we had our evidence review committee look at that. They came back to us and said what many other groups have said. Based on the evidence, we think a long-acting diuretic is somewhat better. But overall, as we looked at the world literature, we came to the conclusion, first and foremost, that lowering blood pressure is the key. And so we said it is acceptable to start, if you're starting with monotherapy, it's acceptable to start with either a diuretic, preferably a long-acting diuretic, a calcium channel blocker, a non-dihydropyridine, in particular, an ACE or an ARB. We said, of course, the first starting point is, does somebody have a compelling reason for using another agent that will lower blood pressure? So Have they had a heart attack and they need beta blockers? Do they have stable ischemic heart disease and they need to be on an ACE? So that would be the starting point. If there is no compelling indication in any of those four classes, we did not elevate beta blockers to a first step agents, largely because I think the trials that have been done have used atenolol, which we now know to be a pretty ineffective ACE, a pretty ineffective beta blocker. And newer beta blockers like carvedilol may be good, but we just don't have the evidence. So we did not include that as a first line group, but we said all of the others. And we said in the vast majority of individuals, they're going to require combination therapy, and it's good to start with low doses of combination therapy. And don't be afraid to control blood pressure. That's the key. So, should we start? How should we start pharmacotherapy? What does your clinical experience say, sir? Okay, so clinical experience would be just as I mentioned as we were going through the lecture. Lifestyle is really the underpinning of most people because that's what causes their high blood pressure. And about 90% of people, it's because they have a poor diet and they have lack of physical activity. And like any epidemics, Virchow, who was a great pathologist in the 1800s in Germany, he made a very important observation that epidemics are a manifestation of change in culture. And you never get rid of an epidemic till culture changes back. And we have now a cultural phenomenon as we have changed our lifestyles from what our forebears used to have towards using cars and using escalators and elevators and sitting at the desk rather than doing manual labor. We see it in China. When people come in from rural areas to the towns, they go from about 6,000 calories a day quickly down to about 2,000 calories a day. So there are huge changes in physical activity, and there are huge changes in diet. And unfortunately, our diet, as we've gotten more money, we tend to eat a richer diet that has more fatty meats in it. So the key to causing high blood pressure in most people is poor diet and lack of physical activity, and the key to managing it, the underpinning, has got to be lifestyle change. It's not easy, but it is important. On top of which, pharmacotherapy would be recommended, and we would say especially for those who are at high underlying risk for cardiovascular disease, and in our case, most of the cardiovascular disease is atherosclerotic. That's true for India as well. Most of your cardiovascular disease is now atherosclerotic. So especially in that stage 1, it's important to understand whether somebody has high underpinning of atherosclerosis. Thank you. Okay. I'm not sure of that one. Let's move on. Thank you. Choice of drugs on CKD and diabetes. Well, again, I would say the important thing is if they have high blood pressure, let's try to get it managed as long as it's tolerated. Patients with CKD, and I trained as a nephrologist and practiced as a clinical nephrologist for many years. As you well know, patients with chronic kidney disease, when they progress to end-stage renal disease, they don't die from kidney disease. It's unusual for people to die from kidney disease. What they die from is cardiovascular disease. So they have, for a variety of reasons, huge risk for cardiovascular disease. The important thing here is to try to manage it. And one component of managing the atherosclerosis that is so common in patients with kidney disease and so common in diabetes is effectively lowering blood pressure. I think for most patients with CKD and diabetes, the choice of drug is less important than getting the blood pressure down. And diuretics work very well in both of these settings. If, as I mentioned, a patient has diabetes that is leading to heavy proteinuria, kidney disease with heavy proteinuria, that is where an ACE is clearly indicated. The trials very strongly confirm the value of ACE in that setting. At lower levels of albuminuria, possibly they're helpful, but there's no good evidence for it. And if they don't have albuminuria, there's no evidence at all. And kidney patients seem to have done very, very well with most of the major classes of agents, and specifically with diuretics. So most of these patients are going to require 2 or 3 drugs, and typically they're going to require some combination of an ACE, or if not tolerated, an ARB with a long-acting diuretic, or if diuretics not something you want to use and you don't have labs, then a CCB is a reasonable alternative. But of course, hypertension can be quite difficult, especially with advanced kidney disease, can be quite difficult to manage, and frequently will require 3 or more antihypertensive agents. Which guideline to follow if a patient is hypertensive and age 65 years, patient non-diabetic? I, of course, naturally think that our guideline is the appropriate one. It benefits from the availability of trials that were not available to others. And I think SPRINT has been particularly helpful because it had a large number of individuals 75 years or older. HIVET, which is the other trial, and looks at even older patients, 85 years or older. It's a little older, but it also shows that more intensive reduction in blood pressure is very helpful in older people. So I would say if you're 65 years or older, which I am, what do we want to do? Well, we're on a slope of decline. That's just unfortunately the reality of life. We are on a slope, and we want to try to flatten that slope as much as possible. I want to see my children's grandchildren, my children's children, my grandchildren. I want to get to weddings. I want to get to graduations. I want to be able to live my life on my own terms. And so there are not too many interventions that are effective. One that we now know to be very effective, if tolerated, is lowering blood pressure. And it is very achievable in the trial setting. And for somebody like me who is, I have problems, I have medical problems, including a lymphoma, which is responding well to treatment. I had orthopedic problems because I fell off my bicycle and was badly injured, but I'm otherwise very healthy, active, live a full day, work a hard day. So I'm the type of person in whom lowering blood pressure is highly desirable. Our guideline would say, for me, less than 130 systolic. In fact, I have high blood pressure, and I go even lower than that. I follow what's in SPRINT. I get down to, my pressure's down to about 120 systolic. So that's, I think, one of the interventions that works very well for improving health. Now, if you're dealing with a patient who is older and is really got a lot of comorbidity, or if they're institutionalized or in the hospital, then I think you and the patient have to sit down and have a discussion, and it's shared decision making. And if you think somebody's time on this planet is limited, maybe intensive treatment isn't sensible for them. I think the clinician is always in the best position to advise a patient and make a joint decision. And so we have 2 recommendations in our guideline for the person who is ambulatory and relatively healthy. Intensive reduction of blood pressure we strongly recommend. For the patient who is not so healthy, especially for those who are institutionalized, they have not been included in clinical trials, and we say there it should be a joint decision, shared decision of the patient and the physician. Which antihypertensive drug for diabetics? I think I've covered that already. Really getting the pressure down is the key, and unless they have diabetes with heavy proteinuria, and where an ACE would be recommended as a first choice. Choice of antihypertensive in elderly patient, isolated systolic hypertension. Well, again, it's getting the blood pressure down. And we have to be careful, obviously, in treating anyone, and especially I think we all worry when we're treating older patients with isolated systolic. Will we take their diastolic too low? And as I showed you earlier on, this was a concern for our Data and Safety Monitoring Board in Sprint. I think the key here is, listen to the patient. Is the patient symptomatic? And when you bring them in the office and you do supine and upright blood pressures, do they become symptomatic? And I think that's where we have to back off. I have a very low heart rate. I've cycled 30 to 50 miles a day all my life, or many years of my life. So my heart rate is low. I've always been proud of it. When I go for my rituximab infusions now, they get awfully concerned because my heart rate's under 50. But I explained to them that physiologically, that is quite normal for me. Don't be worried about it. They're worried because rituximab, one of the side effects is partial or complete heart block. So I think we have to listen to our patients. Don't be afraid to try to help them by reducing their risk by treatment, as long as they're tolerating the treatment well. And I think that it's just a matter of monitoring carefully for side effects from treatment. What is the preferred drug of choice for masked hypertension? How aggressively should it be managed? Well, again, any of the agents that from the 4 classes we felt were reasonable as first step: long-acting diuretic, CCB, preferably non-dihydropyridine, an ACE or an ARB. And although there are some differences between ACEs and ARBs, it's not clear at all that there are real important differences in outcomes for any of the different ACEs or ARBs. So any of those are effective and can be used for treating all forms of hypertension, including MAST. We do not have treatment trials for masked hypertension, but the risk is high. So we recommended, based on expert opinion, not based on clinical trials, but based on our opinion, that the risk is high, they probably will benefit. Trials would need to be done in that setting. So that would be my suggestion there. When can you start beta blockers? Younger patients with IHD only. Looking at the evidence of beta blockers, not as strong as the evidence of benefit from other agents. It doesn't mean they're not effective, it just means they're not well proven in most of the clinical trials. And largely that's because atenolol has been the agent used in many of those trials, and now there are many meta-analyses that have shown that atenolol is not an effective beta blocker. So perhaps the newer beta blockers, like carvedilol, is one that's very highly, espoused in the U.S. Maybe they are good, but we don't have the evidence. Some guidelines, of course, do recommend in younger patients veering more towards things that will tend to slow heart rate, like a beta blocker, with the notion that at young age you're dealing largely with heart rate and volume, and at older age you're dealing largely with sodium retention. There may be some truth to that, but it's not very well proven. So I would say the important thing, again, in all these situations is getting the blood pressure down. That's what we really know to be beneficial. I don't have any evidence to suggest that amlodipine has been used in many trials, and that's the one that I would go to. But again, for a lot of these classes, there are certainly within-class differences for CCBs, but most of the dihydropyridines are probably pretty similar. It turns out that we have only certain ones that have been tested in clinical trials. Likewise for ACE inhibitors. ARBs. Thank you. In our rural population, most of the patients are malnourished, low body weight, any dose suggestion required. Good question. Probably not, but again, you will be the best judge of this. I think you're in the best position to know your patients and to see how they respond to treatment. And if you're concerned that they may be more sensitive to the traditional doses that we use for treating adults, you can start with lower doses and see how their blood pressure is responding. And of course, a great way, if it can be afforded, and I realize there's a cost involved, is for patients to be trained to take their own blood pressures. There are many people, including myself, I have high blood pressure, who can measure their blood pressures at home. There are many devices that are well proven and well validated. And they can either electronically send those results to you, or they can bring the device in and spit out those results when they get into the office. And that'll be very helpful for you in understanding how they are responding to their blood pressure meds. Of course, asking them, are you having any symptoms? If they tell you, yes, I'm having fainting attacks, or I'm feeling dizzy when I stand up, then you start to worry. You may not be seeing it in the office, but perhaps they're having some out-of-office hypertension. I have no evidence to suggest that this agent, which is not one I'm familiar with, probably not on the market in the US, is better than amlodipine. I think we're all used to seeing drug companies telling us, I've got a new agent. It's more expensive than what you've been using, but boy, is it worth it. It is fantastic. And, time after time, we've heard that story. And we've heard the story, if you're using diuretics, you're old-fashioned, you don't know what you're doing. But the clinical trials really are our best guide, and the clinical trials would tell us that there's not much difference between most agents within class or subclass in the case of CCBs, and that diuretics are exceedingly good at lowering blood pressure. They've been about the best. The long-acting diuretics have been about the best that we've seen in any trial, and they're typically pretty cheap. 21-year-old, 124, 110, choice of antihypertensive. Well, this is concerning, isn't it? I mean, very high diastolics, and of course in younger age, unlike what we see in the typical adult, at younger age, diastolic can be the driving force for risk. So, one, I would want to make sure that that's well documented with careful measurements of blood pressure on 2 or more occasions, preferably getting out-of-office blood pressure measurements to document it. And then, if really this individual is at age 21 at 110, that's a big concern because the lifetime risk is going to be substantial. Using a traditional calculator for event-based risk is not going to be of any help to you because you're not going to see events at within the next 10 years probably in this person. Possible, but it's unlikely. But what will concern you is that this individual's lifetime risk, if this is a true reflection of their diastolic pressure, has got to be very high. So I would definitely be encouraging them to improve any aspects of their lifestyle that can be improved, and I would definitely be starting them on drug therapy, and they will, at this level, if this is a true reflection of their diastolic, they will almost certainly require more than one drug. My preference is to use a long-acting diuretic in combination with an ACE, but you could certainly use a CCB with an ACE. A very small percentage of people will not tolerate an ACE or will have side effects with an ACE, and there I think ARB is a reasonable substitute. Combinations of these agents all make sense. The only combination that we specifically said do not use is the combination of an ACE and an ARB together, or 2 ACEs or 2 ARBs. that definitely is a source of risk, especially for hyperkalemia, and it has been shown to be detrimental in a number of clinical trials. But otherwise, certainly this individual merits very, very careful attention, and if the pressure is indeed what it appears to be, merits attention. So, I hope you've enjoyed this as much as I have enjoyed it. It's been, as I say on the list, it's been a blast. I wish I could have been with you in person. I look forward to my next visit to India, and if you come to New Orleans, please be sure to be in touch. And thank you for the privilege of being able to speak with you tonight and exchange ideas, and we learn from one another. I often say, disease knows no boundaries, and the only way we're going to manage disease and conquer it is working together across those boundaries. So this has been a lovely opportunity for me to talk about our guideline, and I hope it has been beneficial for you. And thank you so much for all of your attention and the questions. Have a great evening. Look forward to chatting with you again. Bye-bye for now.